This talk is on thrombotic and vascular diseases. Thrombotic disorders arise from a number of different disease processes. And as you probably already know, Virchow's Triad is important in this process of increasing the tendency to create a thrombus. So physiologic alterations predisposing to thrombi include alterations in blood flow, especially slow or stagnant flow, but high velocity flow that might damage the vascular endothelium, which is the second point that we might see. And finally, a condition that leads to an increased tendency to create thrombi, a hypercoagulable situation, which results from changes in coagulation proteins or platelets. There are a number of common causes that can lead to this, and I think the sicker the animal is, the more likely they are to get a thrombotic disorder. Especially in our intensive care unit, animals that are very sick with multiple disease processes are highly likely to experience thrombotic disease process, whereas animals with minimal illness are much less likely to develop thrombus formation. If we think about how we might proceed through this lecture, we could talk about diseases that predispose to thrombus formation and some of the mechanisms. We could next talk about testing for thrombotic disease, and that might either include screening to look for animals at increased risk for thrombus formation, or tests we might do to document there is actually a thrombus present. If we have a thrombus or are worried about a thrombus, then we may want to use some medication to reduce the tendency for thrombosis, and that might include antiplatelet drugs, anticoagulant drugs, or thrombolytic drugs. And towards the end, we'll talk about certain diseases that are diseases specific for thrombosis, including arterial thromboembolism in both dogs, cats, although it also occurs in horses, pulmonary thromboembolism, venous thrombosis, and at the very end, we'll talk about a few other vascular diseases. What are the diseases that might predispose to thrombosis or thromboembolism? Well, there are a number listed here. Certainly animals with sepsis or severe infection due to bacterial, fungal, or viral disorders are at increased risk for thrombus formation. Certain cancers have an increased tendency to develop thrombosis. Cats with cardiomyopathy are at increased risk for thrombosis. Dogs with Cushing's disease, either hyperadrenocorticism due to spontaneous disease or of iatrogenic cause, may develop thrombosis, particularly pulmonary thromboembolic disease. Diseases of the arteries or veins may increase the tendency for thrombus formation. Many dogs with heartworm disease get problems in the pulmonary artery and they may develop thrombosis, especially when the worms die. Protein-losing disorders like protein-losing nephropathy or protein-losing enteropathy can increase the tendency for thrombus formation. Certainly direct vessel injury, the placement of a catheter or the long-term indwelling of a catheter or installation of irritating or hypertonic fluid can increase the risk for thrombus formation. And shock or severe illness from any cause. The animal in the picture there is a large breed dog with multisystemic disease who is not moving at all, who is probably at high risk for thrombus formation. Diseases that affect red cells or platelets or hyperviscosity syndrome can increase the tendency for thrombus formation, and the same is true for diseases associated with platelets that either lead to high or low platelets or increased reactivity of platelets. And finally, animals with disseminated intravascular coagulation go through a hypercoagulable phase before they become hypocoagulable. Another way to look at the Virchow's Triad is to consider each of these individual disease processes and how we might see alterations in either endothelial damage or increased tendency to coagulate, or alterations in blood flow. And some diseases like feline cardiomyopathy have all three of those affected, whereas other diseases may only have one or two abnormalities. One of the main mechanisms for thrombus formation is a reduction in antithrombin. Antithrombin is generally considered to be an anticoagulant inside the body. It inactivates thrombin and other clotting proteins. And the effect of a loss of antithrombin is to create a procoagulant state. Modest reductions in antithrombin can predispose, especially if seen in the presence of other things that also might predispose to thrombus formation. And antithrombin deficiency can happen secondary to a number of diseases, including decreased synthesis, increased consumption, loss of antithrombin through the kidneys or through the gastrointestinal tract, or diseases that are associated with increased protein catabolism. Other factors that are involved in the anticoagulant systems in the body are protein C and protein S, which are vitamin K dependent proteins that inhibit the procoagulant system. And congenital deficiencies of these have been described. And there is also, when you start Coumadin, a brief period of time where both protein C and protein S are inhibited by Coumadin before the remaining procoagulant proteins are inhibited. Finally, the presence of multiple concurrent disorders may be an additional predisposing factor for thromboembolism. Cats, one study identified that when pulmonary thromboembolism was noted at necropsy, almost half of them had multiple disease processes that could predispose to thrombus formation. Testing for thrombotic disease could be divided into two categories. The first was to consider tests to confirm the presence of thrombotic disease, and the second would be tests to increase the suspicion or concern about the development of thrombotic disease in the future. We'll take each of these individually and start out with tests that confirm the presence of thrombotic disease. Thrombosis may be identified on abdominal ultrasound, which can confirm the presence of aortic or iliac thrombosis. And ultrasound of the abdomen may also identify infarcts in the spleen, kidneys, or other organs, which would increase the concern for thrombotic disorders. Echocardiography is sometimes used to try to identify thrombus, and we may see thrombus inside of a cardiac chamber, or we may see changes inside of the heart that may increase the risk for thrombus formation. For example, in a cat with cardiomyopathy and marked left atrial enlargement or spontaneous contrast, that cat would be considered to be at increased risk for thrombus formation. Finally, in animals where we're worried about pulmonary thromboembolism, we may see right heart enlargement or pulmonary artery enlargement or pulmonary hypertension. On occasion, selective angiography is used to document the site of thrombosis and the reduced blood flow after the thrombus. CT angiography is especially useful to diagnose pulmonary thromboembolism. We'll show a picture of that in a minute. And finally, magnetic resonance imaging is useful to identify thrombosis affecting the central nervous system. Here's a picture of the aorta and a thrombus present between the blue arrows. This thrombus was noted at the terminal end of the aorta near the trifurcation. This is an uncommon picture, but we see a short axis view of the aorta and a markedly enlarged left atrium from a cat with cardiomyopathy. There's also some spontaneous contrast as well as a large thrombus bouncing around inside the left atrium. Selective angiography, in this case of the aorta, documents an abrupt termination of contrast between the blue arrows with a marked reduction of flow after the presence or location of the thrombus. CT angiography is probably the best test to document pulmonary thromboembolism. This is a short axis picture through the right ventricle, left ventricle, and aorta. You'll notice that those structures are full of contrast in that they're white. And the pulmonary artery has a little rim of white, but the central region of the pulmonary artery going to the caudal lung lobes is full of thrombus. Next, let's talk about tests that might increase the suspicion or concern for thrombotic disease. These tests are often performed in an animal that has a disease process that predisposes to thromboembolic complications. And abnormal tests might trigger greater concern for thrombus formation and might cause the clinician to start to consider whether or not to use an antithrombotic medication. Platelet counts that can be seen either with thrombotic disease or with an increased tendency for thrombotic disease would include thrombocytopenia or thrombocytosis. Many animals who have thrombotic disease actually have thrombocytopenia. Prothrombin time and activated partial thromboplastin time may be abnormal, and prolonged clotting times may indicate a suspicion for a consumptive coagulopathy in an animal with a multisystemic disease process. D-dimers seem to be less useful in dogs and cats than they are in people. D-dimers are a fibrin degradation product, or FDP, that is seen with thrombolysis as the thrombus is starting to be broken down. Thromboelastography is positive in many animals with severe systemic diseases, whether or not they are at increased risk for thrombosis. So some proportion of these animals will develop thrombosis, although some animals that already have a thrombus present have a hypocoagulable TEG with enhanced fibrinolysis. So this test is only moderately helpful in increasing the suspicion for thrombotic disease. Finally, antithrombin levels can be measured, and low levels may increase the concern for development of thrombosis in the future. Then we may have drugs that are used to either treat thrombosis or drugs used to try to prevent thrombotic disease. We'll talk first about drugs that are predominantly used to prevent thrombosis, although these drugs are also used sometimes once a thrombus has been confirmed or documented. We'll talk first about antiplatelet drugs, then a series of anticoagulant drugs, and then we would talk about drugs used to treat a confirmed thrombosis, which again might include the same drugs, but might also include thrombolytic drugs like tissue plasminogen activator. Clopidogrel is a drug that is used to prevent thrombosis. It's an antiplatelet drug. The mechanism of action is that it irreversibly blocks ADP binding to the P2Y12 receptor on the platelet surface, leading to inhibition of the modification of glycoprotein 2B3A receptor and reduced platelet aggregation. There's no specific monitoring for clopidogrel, and side effects are uncommon for bleeding. It's possible to see injection site bleeding, excessive bleeding at surgery, or hematuria. The most common would be that the drug has a bad taste and can lead to foaming at the mouth, and thus sometimes it needs to be hidden inside of another capsule for administration. In cats, there's a side effect noted, a hepatic disorder that can lead to vomiting, anorexia, icterus, and increased bilirubin. That seemed to be reversible with discontinuation of the drug in most animals. And it is a drug where hepatic metabolism is required, and there's variable conversion in animals. Thus, it's possible that you give a dose of clopidogrel that should be effective, but that particular animal does not convert it reliably, and there's little antiplatelet effect. Aspirin is the next drug we might talk about to try to prevent thrombosis. It is also an antiplatelet drug. The mechanism of action for aspirin is that it acetylates cyclooxygenase 1 in platelets, leading to the inhibition of thromboxane A2 synthesis, thus reduced platelet aggregation. There's no monitoring required, but the correct dose of aspirin is debated, and depending on the study you look at and whether they're looking at a surrogate endpoint or not, wide range of doses are recommended for aspirin. Side effects can include gastrointestinal ulceration or vomiting or anorexia, particularly if there's reduced perfusion to the GI tract, which can then lead to gastrointestinal bleeding. We worry a little bit about the kidneys in animals that are volume depleted, which can sometimes happen with diuretics. And finally, for animals that have heart failure, aspirin can potentially make diuretics less effective. So that's a concern for use in cats with cardiomyopathy who already have congestive heart failure. Unfractionated heparin is sometimes used to try to prevent thrombus formation. Heparin is an anticoagulant drug. When we talk about unfractionated, that's the regular heparin, which has a great variety of molecular weight sizes inside of it. This binds to antithrombin, which then inactivates thrombin, factor Xa, and other proteases to create the anticoagulant effect. Unfractionated heparin is administered by a variety of different ways, can be given subcutaneously, and depending on the situation, it might be given 3 to 6 times per day, or heparin can be given as a continuous rate infusion. The dose of unfractionated heparin is adjusted based on prolongation of the activated partial thromboplastin time. Most people would shoot for 1.5 to 2 times the baseline, and unfractionated heparin is often given for 1 to 5 days. Side effects can include bleeding, especially from injection sites, or hematuria. Low molecular weight heparins are special small fragments of heparin that act again as anticoagulants. Enoxaparin and dalteparin would be examples that are used in veterinary medicine. They have a longer duration of action than unfractionated heparin, although they still require sub-Q administration. The mechanism of action is mostly to inhibit activated factor Xa, so block factor Xa, although a little bit of effect may be to inhibit thrombin as well. These drugs usually are given 2 to 3 times per day, depending on the clinical setting, and no routine monitoring is required. Side effects can include bleeding at injection sites or catheter sites or hematuria, and these drugs can be expensive to use on a long-term basis. Warfarin is the old standby used to try to prevent thrombosis, although it's used much less commonly now. It's an anticoagulant drug with a mechanism of action to inhibit vitamin K-dependent clotting factors 2, 7, 9, and 10. This leads to prolonged clotting times, both PT and activated partial thromboplastin time. Quite a bit of monitoring is required in order to effectively use warfarin. Serial measurements of prothrombin time are required to assess the degree of coagulation and the prolongation in prothrombin time. Prothrombin time is usually recommended to be prolonged somewhere between 1.5 and 2.5 times baseline, depending on the goal or indication. And the international normalized ratio is used to try to standardize tests. Usually the prothrombin time is checked within 5 to 7 days initially, and then 1 to 2 weeks until a stable dose is identified, and then at least monthly after that point in time. Side effects can include potentially lethal bleeding and anemia. This is often internal bleeding rather than external bleeding, which means that this complication may not be recognized until it is very advanced, and animals often just present with lethargy, weakness, not feeling right despite having lost a large volume of blood internally. Frequent rechecks and dose adjustments can be difficult, and often things change over time as diet changes or some other part of the animal's environment changes, and this often can lead to owner frustration. And that's one of the more difficult things for use of warfarin. And fatal hemorrhage is reported to occur in up to 13% of cats. And as a result of these factors, we no longer use warfarin. Rivaroxaban and apixaban are newer drugs that are anticoagulant drugs, and these drugs will probably eventually replace warfarin for most clinical situations. The mechanism of action is that they're direct-acting factor Xa inhibitors. They lead to an anticoagulant effect that in many clinical situations, at least in people, is non-inferior to warfarin, and there is no monitoring required. The dose may be a little debated at this point in time and likely will be adjusted further in the future. Side effects can include bleeding into the urinary tract or injection sites or GI tract or to the central nervous system, although central nervous system bleeding appears to be less common in dogs and cats than it is in people. And at this stage, there's still somewhat limited experience in veterinary medicine with these drugs. Finally, if we have a documented thrombus in either the distal aorta or in the pulmonary artery, we may try to break down the thrombus with a thrombolytic drug. These are drugs specifically intended to try to reduce the size of a thrombus that's been formed in the body and to work with the body's own fibrinolytic system to help break down the thrombus. The mechanism of action is that they bind to plasminogen on the fibrin surface of the thrombus to convert plasminogen to plasmin, and that then helps break down the thrombus. That's particularly for tissue plasminogen activator. So this leads to a thrombolytic action, and it's usually used when there's confirmed thrombotic disease. Side effects can include bleeding from injection sites or catheter sites or phlebotomy sites, internal bleeding, central nervous system bleeding as well. And at this point in time, tissue plasminogen activator is the only one that's available, and it's quite expensive. Let's talk to certain diseases that are specifically associated with thrombus formation. First, we'll talk about feline aortic thromboembolism, which is a sequela of feline cardiomyopathy, and occurs probably in 10 to 20% of cats with advanced cardiac disease. And intracardiac thrombus is suspected to be the source, most often in the left auricular appendage from a dilated left atrium. Blood stasis and abnormal flow in the left atrium increases the risk for thrombus formation. Cats in general have hyperreactive platelet counts, and further stretch of the left atrium can lead to endothelial damage with collagen exposure and tissue activation. The clinical presentation depends on the site of the thrombus, but at least 90% of cats have a thrombus that develops in the terminal aorta by the aortic trifurcation. This is sometimes referred to as a saddle thrombus. And lack of blood flow to the back legs results in an ischemic myopathy and ischemic neuropathy. Other sites of thrombus formation can include a front leg, GI tract, kidney, liver, spleen, or the heart. Some people try to use the 5 Ps as a mnemonic for the clinical signs that may be seen with aortic thromboembolism or arterial thromboembolism anywhere. Pain, which in cats often looks like vocalization, open mouth breathing, or perhaps the feline grimace, although I think that's not always seen. Paleness or pallor is seen in the nail beds, cyanotic nail beds. Pulselessness, loss of femoral pulse. Polar is cold, the limb is generally cooler than the other limbs. And paresis or paralysis, as identified in the cat in the lower right-hand corner video that had a clot 2 or 3 days earlier and has regained some function to one leg, but is still very weak on the remaining back leg. When there's total loss of arterial flow to the gastrocnemius muscles, those muscles tend to get very firm. Differential diagnosis for feline aortic thromboembolism could include upper motor neuron disease or musculoskeletal disease, such as an intervertebral disc, fibrocartilaginous emboli, trauma, lymphoma. Cardiogenic embolism is, again, the main differential we're considering, which can happen with virtually any form of feline heart disease that affects the left heart. And if the left heart is not the cause in a cat for documented aortic thromboembolism, it can be pulmonary neoplasia. So a mass in the lung can lead either to arterial embolism or what's sometimes termed digit syndrome, which likely is because the mass is growing into the pulmonary vein, gets access to the pulmonary vein, and then circles through the left atrium, left ventricle, and lodges elsewhere in the body. Diagnostic testing. The diagnosis of arterial embolism in cats is usually easy to identify without extra testing. Lack of pulses, cool limb, abnormal nail beds, loss of arterial pulses should all be present in the majority of cases, and additional testing is not required. People have talked about measurement of blood glucose and lactate in the affected limb. If the diagnosis is in question based on history and exam, the blood glucose is usually lower in the affected limb and the lactate is higher. I would encourage you to not do that unless you really have uncertainty about the diagnosis, as it's probably not a good idea to stick a needle into a leg that is relatively devoid of blood supply, as you introduce a wound and a site for bacteria to gain colonization and potentially create an infection in an anaerobic situation. Echocardiography is typically done in animals that have suspected aortic thromboembolism to search for cardiac disease, such as left atrial enlargement, spontaneous contrast in the left atrium, which is sometimes called smoke. Marked left ventricular hypertrophy or endocardial thickening have also been associated with thrombus formation. And finally, if the heart looks relatively normal on echo, you might do thoracic radiographs and a more extensive workup in order to try to search for a mass or some other source for thrombus formation. Most cats with arterial embolism will just have an enlarged left atrium like is seen in this cat and no visible thrombus. They may also have spontaneous contrast. Much less often will we see a thrombus or bouncing around inside the left atrium. This one is so big that it can't make it through the mitral valve, and there's a chance a thrombus like that would get stuck in the aortic outflow tract and cause sudden death. More often in this picture, we have the left atrial body and the left auricular appendage. You can see thrombus in the left auricular appendage as well as spontaneous contrast in the left atrial appendage and the left atrial body. Treatment of arterial thromboembolism in cats is difficult and sometimes is very rewarding, but often is unrewarding. Anticoagulant drugs such as heparin or low molecular weight heparin are often given, and clopidogrel is sometimes given in a loading dose, 2 to 4 times the regular maintenance dose. Analgesics are appropriate. There is some suggestion that there's vasoconstriction of collateral blood vessels, and that led to the proposal that vasodilators might be helpful, but no studies have shown an improved outcome, and I have concerns that vasodilators will reduce the blood pressure and might actually reduce the tendency for collateral circulation to open up. Certainly in some of these animals either have heart failure or the stress of having a thrombus will cause heart failure to be present. But if they don't have heart failure and they just have open mouth breathing, you'd like to avoid administration of diuretics or other heart failure medications, as this also will reduce perfusion to the tissues and reduce the tendency for collateral vessels to open up. So try to avoid dehydration and hypotension in animals with congestive heart failure and concurrent arterial embolism. Thrombolytics are controversial. They've been looked at, and they do result in some increase in blood flow and presumably a smaller thrombus size. However, they can lead to reperfusion injury with a severe situation of hyperkalemia and metabolic acidosis once you've reestablished perfusion to the necrotic limbs. If thrombolytics are to be used, they should essentially be used immediately after the onset of thrombosis, for sure within the first couple hours, to try to save the tissue that might still be viable. Finally, there are 1 or 2 reports of surgery to try to remove the thrombus, although at this stage, this is uncommonly done in cats. Because of the great complications associated with aortic thromboembolism and the fact that maybe only 50% of cats will walk again for a back leg thrombus, maybe less than that for a back leg thrombus with a rectal temperature less than 98.5. Although over 90% of cats with a front leg thrombus will regain function, trying to prevent the thrombus formation is a very useful game. So in cats with known cardiomyopathy and left atrial enlargement or spontaneous contrast, we would probably routinely try to administer an antithrombotic to try to prevent a clot from happening. Clopidogrel is the drug that is used most frequently in cats today. Some people have used aspirin historically, although a recent study showed that clopidogrel was superior to aspirin in preventing recurrent thrombosis, and the dose is a little uncertain. Due to concerns about aspirin, we rarely use it, but a number of people will use a dual antiplatelet strategy where they use both clopidogrel and aspirin. Low molecular weight heparins can also be administered to try to prevent thrombus formation, and some people are starting to use the newer generation anticoagulants, rivaroxaban or apixaban, especially in cats with thrombus already present in the left atrium or who have previously experienced thromboembolism. Some people might still use Coumadin, although warfarin sodium, but we would not use that in our hospital at this stage. Let's move on to aortic thrombosis in dogs. Instead of cardiac disease being the main cause of aortic thrombosis in dogs, with the exception of endocarditis, most cardiac diseases in dogs don't seem to highly predispose to thrombus formation. So it tends to be other systemic diseases that lead to aortic thrombosis in dogs, like diseases resulting in protein loss, protein-losing nephropathy or enteropathy, immune-mediated hemolytic anemia, sepsis, trauma, pancreatitis, or certain large breed dogs like greyhounds and Labrador retrievers seem to be at increased risk for developing thrombus formation. There are 2 main clinical presentations for dogs with aortic thrombosis. The first, which is less common, is acute arterial thromboembolism of cardiogenic origin, very similar to what's seen in cats, with a very sudden onset of lameness, sudden loss of function. There may be thrombosis seen in other organs as well when it's cardiogenic origin. The more common clinical presentation in dogs with aortic thrombosis is that there has been a slowly growing thrombus that's originating in the terminal aorta. And this leads to progressive posterior weakness that gets worse over time. It can mimic spinal disease or rear limb arthritis, and eventually lead to loss of rear limb function and toe necrosis. Again, this is a slowly progressive thing. Often it's mistaken early on for some sort of spinal or arthritic condition, and many of these dogs have received a non-steroidal anti-inflammatory before they're actually documented to have arterial thromboembolism. Diagnostic tests might include thoracic radiographs or radiographs of the spine, CBC chemistry profile, urine analysis to look for proteinuria, thromboelastography or other coagulation testing, abdominal ultrasound to document the thrombus, echo to look for a source of the thrombus, or angiography to confirm thrombus formation. Treatment is difficult, although it seems that anticoagulant drugs are probably the most effective. Certainly you'd like to correct the underlying cause that's led to thrombotic tendency. Heparins may be given acutely. Coumadin, rivaroxaban, or apixaban are probably the most effective treatment for documented aortic thrombosis in the dogs and are currently the preferred approach. Antiplatelet drugs and low molecular weight heparin, in our experience, are usually not enough to resolve arterial embolism, especially one that might be slightly more chronic. Thrombolytics can be used, but they tend to be ineffective if it's a chronic, slowly enlarging thrombus. They may be more likely to work if there's an acute thrombus that has what we might talk about as soft clot, that's not been there for a long time and is not really like a concretion. There are a few reports of success with surgery or stent placement to try to open up the vessels and bypass the thrombus. Let's move on to pulmonary embolism. And pulmonary embolism can have a variety of different things that can lead to it. Diarrhea can lead to thrombosis as a result of a combination of thrombus plus dead worms. Pulmonary thromboembolism is what we're going to talk about most in the subsequent slides, although the pulmonary artery can also be blocked as a result of air embolus, a fat embolus, neoplastic embolus, or foreign body in the intravascular tree that gets lodged in the pulmonary artery. Talking specifically about pulmonary thromboembolisms, the clinical signs might include acute unexplained dyspnea, weakness or syncope due to low cardiac output, typically because there's not enough blood going through the pulmonary circuit to get to the left heart, tachycardia, cyanosis. Right heart failure is possible but uncommon, while right heart enlargement is quite common, hemoptysis, and hypotension. Diagnostic testing for pulmonary thromboembolism can include CT angiography, and this is usually the best choice. The downside is it requires anesthesia. Thoracic radiographs are not very specific for pulmonary thromboembolism. You may see right heart enlargement, or hypovascularity to one or more lung fields, or pulmonary infiltrates or pleural effusion. Echocardiography may identify right heart enlargement in animals with pulmonary thromboembolism. It's uncommon to see a thrombus in the right heart or in one of the branches of the main pulmonary artery, but when you do see that, it's very helpful. And pulmonary hypertension may be documented in a significant number of animals. Hypoxemia and hypocapnia may be identified from blood gas testing or pulse oximetry. Coagulation testing is usually indicated, and a general workup to search for and associated the disease that led to pulmonary thromboembolism is appropriate. Here's an example of echo showing the thrombus. In the first panel, there's a thrombus that's in the caudal vena cava. In the second one, there's a thrombus that's in the right pulmonary artery branch. This is documentation of tricuspid regurgitation velocity to try to estimate the systolic pressure in the pulmonary artery and document pulmonary heart hypertension. Normally, the tricuspid regurgitation velocity is about 2.2 meters per second, such that the difference between the right ventricle and right atrium in systole is about 20 millimeters of mercury. In this case, the tricuspid regurgitation velocity is 4.25 meters per second, giving us an estimated pressure difference from the right ventricle to the right atrium of 72 millimeters of mercury. And assuming there's no obstruction across the pulmonary artery, this would tell us that the pulmonary artery pressure is in the 70 to 75 millimeter of mercury range. Look at this a different way. We've got the left-hand column is the chamber, the right atrium, right ventricle, and pulmonary artery, with normal pressures in millimeters of mercury, normal right atrial pressure of 3, right ventricular might be 25/2, and the pulmonary artery pressure might be 25/12. So the difference in the pressure between the right ventricle and the right atrium is about 22 millimeters of mercury in that situation. And if we look at an animal with pulmonary hypertension, like the one with the Doppler echo, the right atrial pressure might still be 3, but the right ventricular pressure is now 75 in systole because the pulmonary artery pressure is elevated at 75. So the pressure difference, the tricuspid regurgitation velocity, is about 72 millimeters of mercury. This is the example we showed before of a CT angiography with the aorta lighting up with contrast and the right ventricle and the left ventricle lighting up with contrast. The right ventricle is dilated, the right atrium is enlarged, and the pulmonary arteries, identified by the arrows, should be white. They should be filled with contrast, but there's not. There's just a little white rim of blood flow going past them because they're both full with thrombus. So the lack of contrast in the pulmonary artery is documentation of pulmonary thromboembolism. How do we treat pulmonary thromboembolism? The first key is to try to treat the underlying disease. You have to reduce the tendency for thrombus formation. And we might break down treatment to prevention of pulmonary thromboembolism in a suspected high-risk case, or treatment of documented pulmonary thromboembolism. For prevention of pulmonary thromboembolism, heparin, either unfractionated heparin, titrated to a prolongation of the activated partial thromboplastin time, or low molecular weight heparin may be administered. And some people would use aspirin or clopidogrel or maybe both. And in certain situations with previously documented pulmonary thromboembolism, it may be appropriate to consider apixaban or rivaroxaban. Treatment of documented pulmonary thromboembolism could be broken into acutely and chronically. So acutely, tissue plasminogen activator, embolectably, or other thrombolytics may be appropriate, along with heparin, antiplatelets, or anticoagulants. And chronically, rivaroxaban, apixaban, or Coumadin may be used to try to prevent further growth of the thrombus and help the body's fibrinolytic system break down the existing residual thrombus. Venous thrombosis can also be seen. This dog had thrombosis in the femoral vein on the right-hand side and thrombosis elsewhere that led to preputial thrombotic necrosis. Cranial vena cava syndrome is another syndrome that's been described. Mass or thrombus that is either inside the cranial cava or compressing the cranial cava leads to reduction of blood flow from the cranial part of the body to the heart, and venous collaterals must open up to try to get blood back to the heart. This can lead to jugular vein distension or edema in the front part of the body, in the head and neck region, and maybe the front limbs. Many of these animals are sick, they don't feel well, they have a little bit of a dull mentation. And if the thrombus or mass is obstructing the thoracic duct, then chylothorax may occur. Another possible lymphatic disorder is a congenital lymphedema, which can be seen in certain medium to large breed dogs. And abnormal lymphatic formation can lead to edema formation in the back legs. In some dogs, this can be a transient thing when they're young, and other dogs, it's a persistent problem, or may even be more likely to be seen at times when they have severe systemic illness. Differentials for lymphedema would be some sort of occlusion to the back part of the body, occlusion in the caudal vena cava, or hypoalbuminemia, fluid overload, some sort of permeability problem, or vasculitis. Finally, aortic dissection or aortic aneurysm can be seen both in dogs and cats, and as well as in horses. And this can lead to thrombus formation and or rupture of the aorta, with sudden death. The last group of things we might talk about are arteriovenous fistulas or arteriovenous malformations, where an artery connects to a venous structure or to the pulmonary artery without an intervening capillary bed. These can happen peripherally, like on a front limb or in the neck, or they can happen centrally, like inside the chest cavity or in the liver. The AV fistula places a volume overload on the heart, and one of the potential things we can see is a congenital malformation in the liver, an arterial portal fistula, or an arteriovenous malformation. And they can occur peripherally as a result of trauma or as a result of neoplasia, especially by the thyroid gland. Here's an example of a dog that has an arterial to pulmonary artery fistula with 3 serial pictures from the angiogram where a catheter is placed in the aorta and then a selective angiogram is done into an anomalous vessel that in the middle panel goes through a sort of semi-capillary bed, and then in the final lower right panel drains into the pulmonary artery.